Thank you, guys. It's nice to see everyone looking more progressively relaxed as the week's gone on. One of the things I love about these types of conferences is you're hanging around and fraternising and chatting with people from all walks of life, medical walks of life, and all parts of mostly Australasia, but also the world. And so what happens is you get this amazing perspective on cases that we all deal with and cases that we're all trying our hardest to work out the best ways of doing things. I think trauma is one of those things where there's been a lot of teaching over the years that has become mantra and dogma. And I'm not going to stand up here today and tell you the right way to do things, but I'm going to try and bring up some cases that have illustrated potentially some changes in the way we think over the last maybe 5 years. But also at the same time, I would love to hear some perspectives from you guys. So I'm not going to put you on the spot. And as I said, this is certainly not the right way to do trauma. It's a perspective from where I've been training and where I'm working at the moment. But I would love to hear if you've got hands to put up or comments to make, please do. And I think that's where we all learn something. I'm currently based in Auckland, as I think I mentioned the other day. So I work at a quaternary trauma centre, Middlemore. We have all trauma services except cardiothoracic and neurosurge. We're the regional burns unit. We see all spinal injuries north of about halfway through the north of New Zealand. And we get some pretty punchy trauma from some very low socioeconomic areas of New Zealand. So we definitely see some stuff. We also are based around... Sorry, is that going to work now? I'm going the right way? Ooh. Am I doing the right one? For those of you who live in Auckland or have been to Auckland, you'll know that we are based around the Hauraki Gulf. We have a lot of water, and as is befitting of an aquatic culture, we have lots of boats. In fact, it seems that everyone in yeah, I think. It seems sometimes that everyone in Auckland has a boat. I don't have a boat. I've got friends who've got boats, and I think that's the best way to be. They say the two best days of owning a boat is the day you buy it and the day you sell it. I'm going to talk about a case today about a family, unfortunately, who experienced the worst day of owning a boat. So this is called motorboating gone wrong. I'm going to start from pre-hospital, and again, please put up any questions if you've got any queries or concerns. This is a young chap in his 20s who was out with his dad on a fishing boat, or fishing trip, on a speedboat in the Hauraki Gulf. Unfortunately, about midday, they bumped up onto a sandbar, and so basically got a little bit caught. The dad's at the controls. I'm not a big boatie, so I don't really know what they're called, but the forward control. Anyway, the son jumped off the back to try and sort of disentangle and move the boat and asked his dad to push the boat a bit further up the sandbar. Unfortunately, he put the reverse in order and ended up macerating his son. Extensive lacerations to the lower limbs, bilaterally, and the pelvis. And it was quite a mess. There was partial traumatic amputation distal to the right knee, and the left leg was very, very, very shredded. The Ambos got there by boat, did an amazing job in securing the groin wounds, and their estimated blood loss was massive. But they did some incredible work on site. They managed to get a tourniquet on, and they got this guy back to shore. At the scene, he was awake, alert, knew what was going on, which I don't know if that helped or not. He was a wee bit tacky, and his blood pressure was holding for a 21-year-old at that stage. Transport time, once they got him back over the bar, to our hospital was 18 minutes. So, on arrival to ED, he's still GCS 15, he's talking, he's got a clear airway, he's on high flow oxygen because that's what you do. But he was very tachycardic and his blood pressure had dumped. What extremities he still had were cold, and he was looking unwell. He was actively bleeding from the amputation on his left lower leg and his whole groin and right thigh were just shredded to the point where you lifted the legs up and all the tissue just flapped down. It was quite the sight. There was clear pelvic instability. You could move. You could feel the bones moving. So there was clearly pelvic bony trauma as well. Right. So you are the team leader, and this arrives. So we did have some warning, to be fair. So we had some good people in the room. What are our priorities with this guy?
MHP.
Sorry? MHP, brilliant. So that's we're going to talk about that. So for those who don't know, massive hemorrhage protocol. It used to be MTP, massive transfusion protocol, but massive hemorrhage protocol, which is a system. So absolutely. Anything else?
Activate all teams.
Sorry? Activation of teams. Brilliant. You guys are awesome. So it's getting the right people either to be in the room when the patient arrives or knowing that the patient is going to be arrived. And the third thing is something we're all experts at, and that's resuscitating a patient. When I was training, I trained in Christchurch in the South Island. I had an amazing mentor, Dr. Mike Arter, who some of you may know, Professor Mike Arter, sorry. His mantra was, if a patient, excluding head injuries, if a patient arrives in your ED with a heart rate and a blood pressure, they should survive. And I remember thinking that, and through all my training, that actually was something I desperately tried to do the whole time. And sadly, apart from a few failed thoracotomies, we kind of mostly got there. So this guy arrived and he was awake and he had a blood pressure. It was pretty shitty, but he had one. And so in our mind, this guy was going to live. But yeah, so our team activation, well done. Resource activation, massive hemorrhage protocol, and of course, all the resuscitation. So our team activation at Middlemore is known as a Code Crimson. So that's mobilisation of the right surgeons. So we have vascular surgeons on site. We have general surgeons. We obviously have critical care. We have orthopods. So they were all put on high alert. Theatre was informed. Theatre was able to already free up some space. The anaesthetists were on board. They knew what was happening, or they knew aware of the potential. Our radiology services all cleared their ED scanner in anticipation of this guy potentially coming through. And as someone pointed out, we had a massive hemorrhage protocol implemented, and we have a clinician, a dedicated, usually a senior registrar or an ED consultant, who becomes that MHP clinician. And that's how our team gets together. So the resource, again, is the massive hemorrhage protocol. So I think this is something that's changed, and we'll talk a wee bit about the changes recently, but the idea is that you are receiving standardised packed delivery of blood products, not just blood, definitely not just saline. And in our hospital, we have three streams. So we have a trauma stream, we have an obstetric hemorrhage stream, and we have an other stream, and I'll show you those very quickly. But the emphasis is on blood arriving rapidly, the blood bank being aware of what's going on. There's none of this kind of to and froing and sorry, who am I talking to? They're aware of the urgency of these things. And again, association with that, you're having this early hemorrhage control, plus or minus potentially transferred to OT or to interventional radiology for pelvic bleeds. So the idea behind a massive hemorrhage protocol is the prediction of a huge amount of blood. So the ABC score is one sort of system for determining when and if you're going to need a massive hemorrhage protocol. Sometimes people will come in and they're bleeding, but they're looking like they're settling, their obs are stable. So if you've got more than two of those points, then your likelihood of needing a massive hemorrhage is high, and then you just press play and get it going. You can always turn it off. But interestingly, the most powerful predictor is positive fluid on EFAST. Any questions? Just please chuck up your hand if you've got any queries. So this is our Counties Manukau Middlemore massive hemorrhage pathway. You don't have to go through it all now, but as I sort of mentioned, so there's the three streams: the code crimson, which is your trauma. We've got a medical and surgical bleeding, and we've got our obstetric one as well. So there's similarities. It starts right at the start, and sometimes or often our paramedics have given at least 1 gram of tranexamic acid in the field. So sometimes they'll give 2, it depends. We'll top that up to 2 when they arrive. The stat pack, which is the two bags of ONEG blood, that's already in our trauma bay, so that's just sitting in a fridge that gets changed regularly. So we literally had that all hooked up and with a warmer ready to go through, and then the MHP sort of goes down from there. The cognitive load and the bandwidth required for something like this, and I know you're all glazed over already, is massive, and it should never ever be underestimated how hard it is to keep up with how much blood, how much product, when to order the next one, who's got what. So that's why we insist on a senior clinician who knows their shit, and often a nurse as well to act or someone to act as a runner, someone that can be putting the bags up, getting everything going, knows how to flick a warmer on, and with her eyes closed, his eyes closed. So all those things are incredibly important, that it's slick and it's smooth. And we do a lot of our resus training purely around this, and we'll run sims with this kind of thing just so that we're all as good as we can get. I won't go into the coag targets, but as things go on, your packs change and modify depending on what your blood results are coming back showing, how coagulopathic you're getting, are you still bleeding, and where you're going as a disposition. So this has all come around because, as I mentioned before, the dogma and institution of trauma care, which, goes back a long, long way, hasn't really been challenged up until, the last few decades or last decade. Traditionally, it was just normal saline, salty water, which we talked about at length of why it's not the ideal fluid for anything, quite frankly, apart from a wash. And then just purely into RBCs, which again had their own problem. Plasma was either late or never, and platelets, again, was either late or never. What this resulted in was dilution, hypothermia, acidosis, and death. So, here's our guy. So our MHP was activated before the guy arrived. We had the ONEG blood hooked up. He'd had the THC in the field. He had a pelvic binder on. If it was his pelvis, we weren't quite sure where that was going, but it was over this macerated thing. The team got a second tourniquet on, which was higher, and it did look like it was slowing the bleeding. We had this resus was packed, but everyone was actually doing a job. So we had 2 house officers, junior regs, on each leg, pushing down on the groin to just try and prevent any ooze, or as much as they could. And actually, that worked really well. And I mean, we talked about it later at our recap, and I mean they were probably lifesavers. We got a couple of massive IV lines in. We started out stat pack, which was our ONEG, and we just got a few bloods off for what they were worth. And as you can see, he was pretty acidotic, high lactate, HB had already dropped, and that was an initial calcium as well, which we can chat about. So this is 5 to 10 minutes after arrival. So all that happened within 5 minutes, which was pretty good. But already after 10 minutes, the physiology was changing. He'd got more tachycardia. Despite what we were doing, his blood pressure had dropped. Now he was getting signs of reduced end organ perfusion. So he was getting confused. His GCS was dropping. This is not good. There was still ooze from this pelvis. Like, how do you put a hand on a pelvis and stop bleeding? It was just there was nothing you could actually see, but there was ooze. You could see it around the edge of the gurney. And this is what was happening. So it used to be the lethal triad. They now talk about the lethal diamond, and the hypocalcemia is the new element. You've probably heard about the others. And it's this vicious circle. It's like sepsis. It's like your acute inflammatory process that goes on. Each begets the other. The thought around the hypocalcemia is a little bit newer, and we know that can facilitate poor, especially cardiovascular functioning, along with acidosis. And they could all just add to this mess that's going on that's really not doing the patient any good at all. And this is essentially why people die, and very quickly. So we're still at less than 10 minutes at this stage, and not great. So I've talked a little bit about this. the early activation is the key, and I think that's something that where you need your blood bank on board, you need the people in there that know what is going on. There's the 30 to 60 minute delay with FFP being thawed, that's not just sitting around. Platelets come later in our cascade, but still they can get those going. And this all happens just when it goes right, it goes right. And the smoothness and the coordination that occurs when you have your blood bank on board and it's mobilising well is amazing. Right, 15 to 20 minutes. So we're on to our second MHP pack at this stage. It arrives. At this stage, it's had 6 units of RBCs, 4 FFP, first dose of platelets, and we're starting to put some calcium as well. Gas actually looks better. We're actually thinking, okay, this is good. Theatre, we're aware. We've got a single shot pelvis, and can anyone think of why we would get that? That was the only imaging we got in our resus bay.
Instability.
Yeah, instability, because if he's maximally bleeding from a shared pelvis, then he's going to the radiologists, he's going to IR, and he's going to get those pelvic vessels thrombolyzed as opposed to theatre. Or he'll go to theatre first and then he'll go to IR, and that often happens. So if they can't control the bleeding, we know he's got a shattered pelvis. More likely than not, that's where the bleeding's coming from. So that was the one thing we needed to know at that point. Obviously the rest was important. So we continued the massive transfusion. We decided surgery was going to be the first port of call because we could see where most of the bleeding was coming from. The team was already up there. They were prepped. We had a surgical consultant come down just to sort of have a look. He was fantastic. He went back up. The anaesthetist was aware she had already got another box, the next box in our cascade, ready, waiting there in theatre. And then we have a process called the red blanket. So if someone throws a red blanket on our trolley, you literally get a fast passage through the hospital. It's a big hospital, and we don't have our theatres on the same floor even nearby. So you throw that and you get this barrage of orderlies just like chasing through the hospital. It's fantastic. It looks, you normally have someone doing CPR. It's all very dramatic, but it works, and everyone knows what a red blanket means, and that's just a sort of a local thing that does seem to work very well. So just over half an hour after arrival, he makes it to surgery. So ended up having a complete guillotine amputation of the lower leg, groin explanation, massive amounts of small vessel bleeding, nothing big though that needed embolization, which was good. Pelvis was packed. They put an X-fix on, which got all the bones, so orthopedics was there as well. Total of 24 units of red blood, 18 units of FFP, and 3 units of platelets. And he made it out of theatre, which was pretty amazing. Obviously, he was intubated at that stage. He crashed a wee bit on his way to ICU, needed some NORAD. As he warmed up, that was probably just the vasodilation that occurred. But actually did amazingly well. He weaned from his inotropes and extubated day 4. Had a delayed definitive pelvic fixation, and given his age, he was a great candidate, obviously, for rehab. The father and son bond apparently was closer now than ever before. They realised what had happened, and they were even bester mates. But I'm sure, that this patient would not have survived in the crystalline first era. I think he would have gone down that cascade incredibly quickly, and we would have lost him. So it was one of those cases I think you just never forget, not just because of the visuals, but also just the way that the team coordinated. And it wasn't one person, it wasn't the team leader, it wasn't the anaesthetist, whatever. It was just this smooth team running and doing its job, which I think is what we all hope for.
Did they sell the boat?
Good question, actually. Yeah, possibly just the motor. Boats. I'm going tomorrow, so I'm not jinxing
A
it.
very quick question.
Yeah, absolutely.
Was at any time Reboa considered?
We don't have Reboa. I've worked in some units in the UK that have used Reboa. I think this would be arguably one of the potential places where it would work. For those who don't know, Reboa is where you go in through the femoral artery and basically blow up a big sausage balloon halfway, just above. It's above the renal arteries, isn't it? So it blows up the balloon and basically occludes the aorta and allows for damage control of predominantly lower limb or pelvic bleeding. And there's some really good studies, especially pre-hospital use with HEMS in London. Very, very good. Very good comment. Is anyone actually using them in EDs or pre-hospitally in Australia? No. There's been a few studies come out that they've kind of done more damage than good if they're not used well, and I think the numbers that you would need would be probably quite high to get good. So those are my key takeaways from this. Rapid and cohesive team activation is essential. Predict your need for a massive transfusion. So we had such a good handover from the pre-hospital teams that we knew that this was all going to happen. So everything was in place when they arrived, and that's did as much as anything. Early recognition of shock physiology. When you're seeing it happen in real time, it's already on its way down that cascade, and target your resus around that. So, case 2. You still going to Bali? You still going to Bali? Love Bali. Great. Everyone there just behaves. Common sense everywhere. So this is scootering gone wrong in Bali. Older chap, 64, not old, older. Holidaying in Bali. Unfortunately, not his fault. Scooter collision with a car, thrown across the road, landed on his right chest and head, and picked up very quickly in one of the local ambulances. Very short, and wasn't far to get to the BIMC hospital in Denpasar, which is one of the private hospitals. He was normally pretty fit and well, had a bit of blood pressure, hyperlipidemia, but otherwise was pretty fit and well prior to this. So on his arrival, obviously this was sort of secondhand through the Balinese emergency team that saw him. GCS again, 15, obvious right-sided chest injury. He was breathing fast. He was a bit hypoxic. Had clinically decreased air entry on that side and a lot of pain, a lot of crepitus. The minute you feel that crepitus, he's got a pneumothorax or a flail chest. This guy had both. So he had a flail chest and a pneumothorax and in fact a hemothorax as well. As tends to happen, and perfectly reasonably, this guy got a pan scan, head and CT, a little bit of bruising around the temporal lobe. Main pathology though was in the chest, so he had 4 to 9 fractures with a flail, a hemopneumothorax of about 30%, so not massive, but evidence also of pulmonary contusion. So he was sore, he was hypoxic. Fortunately, he didn't have any COPD or other sort of lung pathology to complicate things, but that's enough to be pretty sore. So the initial management was all based around sort of just basically oxygenating, ensuring that his lungs were being rested as much as possible. The critical care in places like Bali is pretty good. And so you'll get everything thrown at you and you'll get every test in the world done, as he did. He was put on some oxygen though, and he had all the right things done. He had some opiate analgesia. They put multiple intercostal blocks in for his rib fractures, and he was put into an HDU ICU and had repeat imaging. So on the subsequent chest film that night, this is what they saw, which was a significantly increasing hemothorax. So the line across the middle there, that's all blood. So that wasn't a great sign. At this stage, they hadn't decided to treat the pneumothorax with a chest tube. At this stage, they did. They popped a 28 French in, and initially 350 mils poured out. He said he felt better, his breathing improved, and then the bleeding kind of settled down. So anything we would do differently back home? Anything anyone else would do, treatment-wise? Yeah. I mean, there's a good argument. You're right. Good argument for a traumatic pneumothorax. Although, to be fair, in Australasia they tend to even treat traumatic pneumothoraces conservatively now. I think when you've got both, you would definitely put a tube in. But a 30% pneumothorax on its own would, in some places, depending on the symptoms, background, comorbidities, pathology, may be treated conservatively. But I agree. I think in this guy, getting a tube in early would have probably helped. Then, There's some very, very excitable doctors in some parts of the world. So we suddenly got a call to say that the local cardiothoracic surgeon wanted to perform an open thoracotomy. He wanted to suck all the bleeding out. He wanted to do a VATS, which I'll talk about in a wee minute, and he wanted to fix the ribs. Now, rib fixation is something they really enjoy over there, and basically it's putting a little bit of metal on the two bits of broken rib and fixing them. We don't do this, all right? I've spoken to numerous cardiothoracic surgeons, and they look at you like you're a retard when you even mention. There are a few very, very, very finite indications for fixing a rib. These guys will fix any rib fracture. I don't want to be cynic, but there is probably some reasons why doing lots of surgery on overseas patients is in people's benefit. Now, unfortunately, this poor guy was on his own. He had no family, he had no support over there. He had a surgeon standing over him going, "You will die if we don't do this operation in 24 hours. So we got involved as the aeromedical team that was overseeing him and looking after him. So we were getting these reports, where we were getting these phone calls coming through going, he needs this operation now, here's the, this is what it's going to cost, he needs it now, he's going to die. And we're just going, okay. The patient was getting freaked out. He had nothing. All he heard is, my chest is getting cut open, I want to get home to Australia right now, which is all very, very fair enough. So, what are the indications for urgent thoracotomy? So there's the emergent ED thoracotomy for penetrating stab wounds predominantly, but any penetrating wound that potentially has resulted in a hemopericardium. There's certainly some sharp, strong, and very relevant indications for that. But for other thoracotomies, and yes, a worsening hemothorax is certainly an indication. If you've got a bleeding vessel somewhere in there, it's not going to stop on its own. They're going to continue to bleed out. The general indications are if there's more than 1.5 litres, which was less than that poor guy's bladder in that rest home, or the bleeding is carrying on at more than 200 mils an hour, which is a lot. If the CT showed a major vascular injury with a blush on a CTA, if there were signs of a cardiac injury, if there was a massive ear leak, those would be the indications in Australasia. This patient had none of those. He'd had a 350 mil out, no ongoing bleeding, and he looked well. There was absolutely no indication for cutting this guy's chest open. So that's, basically just what I've just said. So the issue is, though, you've got this guy over there that's being told, obviously, a completely different story, and we are kind of having to sit back home and say, look, from our perspective, this is not something you need. We spoke to the guy. Our nurses are amazing. They're very reassuring. That you can call us anytime if you get worried, but we're keeping a really close eye on things, and you do not need this right now. Similarly with the rib fractures heal incredibly well. The indications for surgical fixation are very, very, very rare. I've known a few patients that have been in ICU that have had massive flail segments, and they've been kind of fixed. If there's an ongoing severe respiratory compromise, sometimes they'll consider it. But generally, it's regional blocks, it's good physio, oxygenation, analgesia, and they come right. This is the VATS that they suggested. Now, VATS surgery is actually done all over the place. It can be done, most commonly it's done for persistent pneumothoraces. So if someone has little blebs all the way through their lungs and they keep popping, that is something that is actually, and they can basically reseal the pleura together to ensure that you don't keep popping your lung. But really in this case there was, again, no indication that this guy needed anything shoved into his chest apart from a chest tube, which he had. So the next question is, can I get home? Obviously, which is fair enough. So is that big enough? Yeah, it is. So the issues with flying with pneumothorax are quite significant. So if you're thinking back to your physiology, gas expansion, as you go up, gas gets bigger. Exactly. So if you've got any gas-filled space, as pressure reduces, that gas is going to increase in size. So if you've got trapped air in a pneumothorax, that is going to get bigger and bigger and bigger and potentially tension and die. So there's some real risks with flying with a pneumothorax. So the standard approach is you have to wait. So once the chest drain comes out, so the pneumothorax re-expands, chest tube comes out, then it's generally a minimum of 7 days rest, and then you get a re-x-ray to make sure it hasn't reoccurred. If that's all clear, then you can fly. The alternative to that is an aeromedical air ambulance back home again, flying at sea level. Now, the likelihood of getting that is not very high. There's a lot of cost involved with a sea level flight all the way from Bali to Australia, and your insurance company would much rather you sit in a nice Balinese hospital for 2 weeks than spend $650,000 and fly you back home in an air ambulance. So, but anyway, it's all about where you are. But those are sort of things that do come into into the thought process, and explain to the guy he can't just jump on a plane. He goes, well, can I just get on a boat? I'm going, what, just on your own? So, and it's horrible being in a place, on your own, with cultural, difficulties, language difficulties. It all adds up, and it is challenging to a patient. So after we kind of had a chat, and as I said, our nursing team is amazing that deals with this sort of stuff. And they're great. They're going, now, can you just check that you're on antibiotics? How do I do that? Just look at the chart at the end of your bed. And I'm on this. No. Okay, now, in the nicest way, can you please ask the nice doctor to put you on some antibiotics? So sometimes you've got to sort of cajole these teams to do things. And so, obviously, the risk of an empyema in a foreign country, there's all these things. So he was on antibiotic. He actually was getting some good physio. He was quite a fit guy normally, which did help again. He was getting reasonable analgesia. They're good in Indonesia with that. On day 4, his chest tube came out. Lungs looked great. They keep wanting to CT them. They're doing a CT every day, I think, also. But I said, no, look, he just needs a chest X-ray in 7 days. He got that. Lung came up again. His wounds were all sort of healing, and this is about day 16, I think. He looked really well. He felt really well. We offered to send a nurse over to fly back with him. He didn't need that. He came home on his own and has done really well. So again, I think the take-home message is, and again, I think this is coming into our practice, is the conservative approach to a lot of these things where we used to just fire in and stab things, and we all love, stabbing and doing words, but a thoracotomy in particular, there's very, very, very few criteria for that. We don't fix ribs. You've got to be very, very careful if you had a pneumothorax and you wanted to fly on a plane. Trauma care and aviation medicine, there's a lot of really interesting crossovers there, and a lot of things we deal with multi-trauma patients in the middle of nowhere, how to get them to somewhere where they can get an optimal assessment. We get a lot of surfers off the coast of Sumatra and these tiny wee islands with just little medical huts, and so it's getting them to a base or somewhere where we can get some imaging to know what's going on, and obviously allaying concerns and stresses as well. So my final question would be, what was the greatest risk in this case? Was it riding a scooter in Bali, the hemopneumothorax and the associated trauma, an enthusiastic surgeon and the proposed thoracotomy, or forgetting your travel insurance? D. No, in all seriousness, and I know some people kind of fly in the seat of their pants sometimes, and even in places like this, people going on, I'm not going to freak anyone out, but credit card insurance is very, very, very average, very basic. They will look at ways of getting out of it. For places like it's a couple $100 for a week in Thailand, it's nothing, and it's worth getting some good travel insurance that will get you out. You'll have someone on the phone to talk you through stuff, and I'm happy to talk to people about this if they have any questions, because we deal with this all the time. But travel's fun. You don't want to dwell on the moody bits, but you also want to be prepared. Thank you.
Thank you very much. Is there any other questions for Brett before we move on? Yeah, Marcy voice.
When you're internationally evac, is it the closest appropriate hospital in Australia, or so like Bali to Melbourne, Bali to Sydney, Bali to Dublin? Where does it decide where you go?
As in when you come back to...
If you are medevaced out.
Yeah, good question. Depends on how sick you are. So for example, if you've been stabbed by a spear in PNG, you probably get into kids. Although they're quite well within their realms to say we don't have any beds, and so then you've got to start hunting. So if you're from Queensland, for example, you'd start in Brisbane, probably work up, and those flight times aren't too bad. But Bali to Perth's great, like that's easy.
Sydney, Melbourne.
Sydney, Melbourne, yeah, and I mean, obviously, it's all population based. If they're not too critically unwell, we'll try and get them back home because A, they're going to be around family and supports, etc. And it's easy to get them into a domiciled hospital where they are. The repats are a lot easier because you've got time to walk and plan those. But say it's an ICU to ICU transfer, you've got to have a place to come back to, obviously.